When I was asked to give this talk, I went through kind of all the different talks that I had prepared in my mind or in my computer, and thought about what would be the most relevant and the most interesting. And of course, today I spent the morning being like, this just isn't sexy enough. I should talk about why everybody keeps asking me for testosterone, and like about the kinds of surgeries we do for sexual medicine. And then I had to step back and remember the reason I wanted to give this particular talk is because we are a multidisciplinary department, and progesterone and progestins, which the combo we would call progestogens, actually crosses all divisions and subspecialties here. So we talk about progestins and progesterones in adolescent medicine, in reproductive age people. We talk about it in the menopausal transition. We talk about it in the postmenopausal transition. We talk about it in cancer survivorship. And we talk about it a lot in complex family planning. And so it really becomes this really lovely blend of our subspecialties here. And so what I'm hopeful I'm going to do today is get you excited about progestogens, because I actually think that progesterone is kind of the forgotten hormone. We talk about estrogen all the time, all the good and all the bad. Everybody's excited about testosterone, which I love talking about and can talk about all day. But progesterone actually is a really interesting sex steroid that I think we've always just assumed the only role it plays is in the uterus. And I'm here to kind of make a case for all the different things it does and help you to be familiar with the different therapeutic uses that we have and the different types of progestins and progesterone formulations out there. So these are my disclosures. I've been doing various work recently with an educational company that provides free videos on all kinds of women's health products, including hormones. And so some of the topics I discussed today, you can actually, if you're like, what is that question? You can find online. And then one of the organizations that I work with actually writes the guidelines for how we do surgical care. And I just bring this up because when you're fighting with an insurance company and they're like, this is not my policy, this is MCG Health's policy, you should know that most surgeries, 80% are actually, there's a third party group that actually writes guidelines for hospitals and insurance companies. And it's actually nice to, they're a middleman essentially. So it's not insurances trying to deny us, and it's not hospitals trying to just make money, but we actually do evidence-based guidance in terms of how we think about surgical procedures. Okay, so what is progesterone? We're going to talk about that. We're going to talk about progestins versus progestogens. So progestogens are all the progesterone and synthetic progesterones, which are AKA progestins. We're going to talk a little bit about what progesterone does in gynecology, and then we're going to talk about what it does in the rest of the body. And one of the things that's most interesting about progesterone is its role in reproductive mood disorders. And we see this over and over again throughout the lifespan. And I want to talk about how we can think about progesterone's role and then think about how we can treat our patients. Okay, so what is progesterone? It is a steroid. All right, so steroids are all basically characterized by the same similar basic structure. This is considered a sex steroid, and there are three kinds of sex steroids. We know this: progestins, which are characterized by 21 carbon atoms, androgens, which have 19 carbon atoms, and estrogens, which have 18 carbon atoms. So regardless of how and where progesterone is made, the biosynthetic processes are actually exactly the same. And the types and amounts synthesized really depend on the expression of enzymes specific to certain organs. So most of the progesterone that is made in the body with ovaries, I always, I'm going to use the word woman, but there are people who don't identify as women that have ovaries. Most of it's made in the ovaries. Okay. First question. Progesterone synthesis occurs when? In relation to estrogen and testosterone. Is it before? Is it after? Is it a totally different pathway, or you have no idea? So for the 6 people here, is it before? I saw Elena. Okay. Is it after? It's been 40 years. All good. Is it after? Is it totally different? Is it no idea? No idea. Okay. So the way to think about this, you guys, I already said it. 21. If you start with more and you think about synthesis, it goes down. All right, think about cleavage. So it's before. What's interesting about progesterone specifically is that it actually it's like totally separate. This pointer doesn't work, does it? I think I said I didn't want one, but I kind of am interested in it because what you can see is if you start with cholesterol on the upper left, and then you move down the yellow, you can turn it on for me. The yellow, it's really early on that you see progesterone. It's like the second step in sex steroid synthesis. So it actually happens really early. And what's cool about progesterone specifically is depending on what enzymes are being expressed, thank you, it depends on what enzymes are being expressed, right? We always talk about 21 hydroxylase, right? That's how you're gonna end up going towards glucocorticoids and mineralocorticoids. So progesterone can turn into the aldosterone synthesis pathway. It can go into glucocorticoids, but then if you go down, that's when you start getting into androgens, right? Androgens are 19, and then estrogens, which are 18 carbon atoms. So the reason this is important is that unlike estrogen and androgens, progesterone actually can target or be metabolized into products that target multiple different receptors, right? And this is really important when we think about its clinical applications and why we may end up with different side effects based on the type of progestins we use. Okay, so what does progesterone do? In the endometrium, this is, the only thing we think about is, oh, the only time you need progesterone is if you're in if you have a uterus, right? In the endometrium, it's very important. So during the proliferative phase in the first half of the menstrual cycle, there's a predominance of estrogen receptors, right? It's an estrogen dominant part of the menstrual cycle phase. But during the ovulatory phase, after you ovulate, and then once you're in the luteal phase, the estrogen concentration, the receptors drop rapidly, and then progesterone receptors increase. And you can see here, this is, again, I have all different types of graphs of the menstrual cycle, and I'll show some of them here, that the luteal phase, as you know, is dominated by progesterone. You don't really make progesterone at any kind of measurable concentrations without ovulation. This is very important because we oftentimes see people come in and they're like, I'm estrogen dominant, because if you look online about progesterone, there's like progesterone dominance, estrogen dominance. And in the perimenopause, everybody will come to you and be like, I'm estrogen dominant, you need to balance me out. They tested my hormones on day 3 and I had no progesterone. That's right, you didn't ovulate. Right? Anybody who checks their progesterone it's going to be negative. And in perimenopause, a lot of these people aren't ovulating. And if they are, they have lower levels of progesterone. So yes, it's for every single person that goes through perimenopause, you're going to start seeing less and less progesterone, but it's certainly going to be negative, like not negative. It's going to be less than 1 if you didn't ovulate, which is common. Okay. So in menstruation, progesterone is entirely produced by the corpus luteum. Levels are less than 1, as I said, unless there is ovulation or exogenous progesterone. So you have to know, are they on it? There's slight increases that happen right around the time of ovulation, and it may help trigger ovulation. High levels of progesterone will inhibit ovulation, right? There's a negative feedback. This is why every single hormonal contraceptive method we use utilizes some form of progestin, right? Because it suppresses that LH surge. The corpus luteum will degenerate after 10 plus days in normal healthy ovaries, right? As you get older, or people who have this luteal phase defect, it might be a little bit shorter. But if there is a pregnancy, the corpus luteum will keep sustaining the progesterone until the placenta takes over, right? And it does that by metabolizing maternal LDL into progesterone. Okay, so that's why in IVF pregnancies, thank you, David, for being here, we give people progesterone because they don't have a corpus luteum. This wasn't a spontaneous ovulation. We need to give them exogenous progesterone until the placenta takes over. So in pregnancy, ovarian cellular cholesterol is converted to pregnenolone, and then you end up getting that turning into progesterone. There's actually follicular fluid that has progesterone. There's lots of roles for progesterone within pregnancy and fertility. I always tell people, the progesterone's role is to get the uterus ready for a pregnancy. And it basically helps, and then it blocks, it's antagonistic to the effects of estrogen and the proliferative aspect of progesterone. So I just say it stabilizes the endometrium, gets it ready for a pregnancy. If no pregnancy occurs, the corpus luteum shrivels up, progesterone drops, estrogen drops, and the withdrawal of that progesterone is what leads to bleed. Okay. Okay. So that's well established. What about progesterone and breastfeeding? So progesterone and progesterone receptor B specifically are really important in mammary gland development. And so this works kind of in concert with insulin-like growth factor, so IGF-1. The reason this is important is that in pregnancy, the high levels of progesterone actually inhibit lactogenesis, right? So that's, people get colostrum, they get all this breast development, but they're not making milk. It's when the progesterone drops that actually is what triggers lactation. And so when the placenta is removed, the progesterone drops, and that's why people's milk will come in a couple days later. This is why people get concerned that hormonal contraception inhibits breastfeeding, because all hormonal contraceptives have some form of a progestin. So it's a reasonable question. It just hasn't really been borne out in the literature. And it's interesting because we're like, we'll give everybody a progestin only method and that's going to work. And I'm like, but it's actually the progestin that's the problem, right? And there is some thought in the kind of midwifery community that, and I wouldn't say that it's a thought. I think there is this question of if there's retained placenta, right? If there's retained placenta, people might still be making progesterone. And so it's triggering that, like if people they don't have good milk letdown, some people will say, could you have retained placenta? And it's because of the progesterone. Okay, this is just too busy for you to know, but the main thing is that this idea in gynecology that the only place progesterone has a role is in the uterus is just flat out wrong. So this is a table that shows all the organs that we know of that have progesterone receptors. It is everywhere. And the reason this became interesting to me was as a resident, I think I was sitting in one of these lecture halls and one of our really great CRH researchers talked about progesterone receptors in the brain. And this triggered this idea for me of, wait a second, there's probably a whole lot about progesterone that we don't know. And the way that I was taught to think about it is probably wrong. And over the years, there's been more and more studies showing where progesterone receptors are. So these are this is a smattering of, this is busy of some of the stuff that progesterone does. In the central nervous system, it induces anti-apoptotic cell survival pathways. We know that it actually increases seizure threshold, right? So we give it to people with seizure disorders. There's a lot of progesterone receptors in the brain. In the GI tract, there's actually a lot of roles of both estrogen and progesterone. Specifically with progesterone, it has to do with smooth muscle contraction and relaxation, which decreases, right? The contraction decreases. This is why they get so constipated, right? There's physiologic reasons for it. It's the hormones. Estrogen has a more protective effect on the mucosal barriers and kind of maintaining the microbiome, but progesterone actually works more on the muscles. In the pancreas, people actually, if you give progesterone, it can cause proliferation of pancreatic cells. In the liver, it affects lipid metabolism. In the respiratory system, if you give people progesterone, it actually helps with vascular endothelial growth factor, and it can help decrease or enhance expression and ventilatory response to carbon dioxide. So it helps with clearing the lungs and it helps with breathing. So this receptor is everywhere. So in gynecology, how do we think about it? So in abnormal uterine bleeding, we use progestins and progesterone. Well, I wouldn't use progesterone, and I'll explain why. We use progestins all the time. And that's because they work very well to affect the proliferation of endometrial cells that can cause abnormal bleeding. So it downregulates estrogen, it blocks proliferation. We know for dysmenorrhea that's related to menstruation. If we block menstruation, block proliferation, it can help with that. Endometriosis is obviously where we use it a lot, but I think what's really interesting about endometriosis is about 30% of endometriosis cells are not responsive to progestins. That's why there's so much treatment failure. We're giving them the best we can, but endometriosis tissue looks different from endometrial tissue. I can talk about this all day, but there's certain receptors in endometrial tissue, mainly estradiol receptor A. In endometriosis tissue, you see a proliferation of, or a predominance of the estradiol receptor B. It's a different receptor, and it's not as sensitive to progestin. So that's why they fail. Okay, let's talk about natural progesterone. So natural progesterone is this, the idea of bioidentical. This is what looks chemically identical to what the ovary makes. You cannot commercially make natural progesterone. It has to be extracted and synthesized from soybeans and Mexican yam root. These are the only two places. And some places, you know, they've been able to get it from ovaries, but that's very expensive. So because you can't take natural progesterone, what they've done is they've created micronized progesterone. So that basically increases the half-life. So the reason if you take natural progesterone, it breaks down immediately. You can't get a blood level, it doesn't work. So we micronize it, and so that it's easier to make it accessible in the body. It decreases the particle size, and it enhances the dissolution. One of the things that's interesting about progesterone, it's 21 carbons. It's a big molecule. Natural progesterone will not absorb through the skin. I'll repeat that over and over again. So when you see the patients who are like, I'm using progesterone cream, this is all I need, it does not work. It is too big a molecule to get through the skin. There are ways to get progestins through the skin, and we'll talk about that. But natural progesterone, it is not the case. I once had a patient who was like, but Dr. Rowen, I doubled the concentration. Look, my progesterone level, like they're testing their levels, it was 2, now it's 4. And I'm like, what is a normal progesterone level in an ovulatory person? Someone call it out. What's a luteal phase progesterone that you'd like to see? 10 plus, right? So 4 is quite low, right? So if someone's like slathering themselves in progesterone cream and they only get to a level of 4, it's pretty hard to say whether or not that's going to be protective when we know that the average or a good level in an ovulatory person is up to 10. Okay, so that's really the main thing about progesterone, the way we take it bioidentically. Now, if you're going to take micronized progesterone, you actually get absorption twice as good absorption if you take it with food. All right. So when we're advising people to take it, I tell them to take it at night because it's a neurosedative. So it can make people very drowsy. But they should be taking it, you know, sometime after dinner, basically, so that there's food. You can also place it vaginally. It gets very well absorbed through the vagina. So micronized progesterone, that's a really nice transdermal way to get it. All right, so that's the story for natural progesterone. Let's move on and talk about progestins. Okay, question number 2. Progestin generations are based on the effects on the androgen receptors. Who thinks that's true? Who thinks that's false? Most people. Who thinks that they're not sure? More people. Awesome, this is why we're here. Okay, so a lot of times people will say this, they're like, oh, the generations, it's because the first generation is more androgenic, and then the further down you get, right, you get to drospirenone, it's anti-androgenic. It's a great theory, it's actually not true. It really has to do with when they came out. It's a marketing trick. Okay, so I'm just giving you a graph here. These are the generations, right? The earlier ones that we talk about are norethindrone is up there, medroxyprogesterone, megase, all of those are actually considered first generation because they're the earlier ones, but they have totally different structures, as I'll explain. Second generation is levonorgestrel, right? So that's second generation. Third generation, desogestrel, norgestimate, gestidine, etinogestrel. Those are ones we oftentimes see in our birth control pills. Many of those are metabolites, actually, or they metabolize into levonorgestrel. So it's, you know, it's interesting, like it's all a marketing trick. And then the fourth generation are the newer ones, nomegestrol, nesterone, dienogest, and drospirenone, which is actually totally different in structure. So the way you really want to be thinking about progestins when you're talking to a patient is what's the structure of the progestin, right? So these are all the synthetic ones. So you want to be basically breaking it into what looks like progesterone and what looks like testosterone. And in the kind of main ones that we oftentimes use, we're thinking about estrins versus gonades. And I'm not going to get into there's all kinds of structural aspects of this, but it's not that important. The main thing to know is what's interesting is the ones that are related to progesterone are ones we don't see as much in combined hormonal contraceptive pills, but you will sometimes see a patient who's taking like megase, for example, right? We don't use that, but you'll sometimes see patients who are getting like nomegestrol, right? They'll come in with these ones and you're like, what is that? Or cyprotypterone, right? You'll see those. Actually, cyprotypterone is more progesterone-like, but they'll come in and these are available in Europe, for example. So when they come in and they're like, what is this? The main thing to say is it's not available here, but if you're trying to figure out what the right pill combination is for them, you need to think about what structure is the pill that they're taking, what type of progestin it is. So when I'm taking a history, someone comes in and they're like, I've tried every single pill there is, nothing works, but I can only be on pills, for example. And I take a detailed history. Essentially what I do is I pull up a chart that's as obnoxious as this, or usually I literally just Google. And I'm like, tell me the name. I don't know what Opry is, Gianvi, like all these, weird names they tell me. I literally just Google what the pill is and figure out what was the progestin in that pill. Because if they say I am intolerant to every pill, I am sure I can find a progestin that looks different than all of the ones they've tried. Does that make sense? So when I was in training, it was just pick a pill, any pill, they all work the same, pick which one's your favorite. And I'm just going to say you need to individualize it for certain people. What are their goals? Because we actually see different responses on different types of receptors. The first and second generation are more androgenic. Levonorgestrel is more androgenic. That's why a side effect of the Mirena, right, is acne. People are like, I'm getting acne. I've never had acne before. And you're like, it can't be. It's only localized in the uterus. No, it's getting into the bloodstream and it's targeting androgen receptors. I'll see the same thing when I give somebody norethindrone, which I love. I like the androgenic ones. I'm a sexual medicine person. They actually have better sexual side effects. So I usually start with those. But some people will come in literally with an OCP. It has ethinyl estradiol. We know their SHBG is elevated. We know their testosterone is low, but they're getting acne. But it's because this combined pill is targeting their androgen receptors because it has norethindrone, for example. So I need to switch them to something else. All right. So these are just some of this is what I want to talk about in terms of progestins. I'm going to switch now. We're not going to talk about combined pills. We're going to talk about what's available in terms of progestins. This is just one example. I'm going to get into some of the newer ones that we have, but medroxyprogesterone acetate, that is Provera. We use it all the time. Depo-Provera, depo-medroxyprogesterone acetate is just a long-acting form of that. Right? So if someone says, I can't tolerate Provera for my abnormal bleeding, it probably isn't the person to give Depo to. All right? It's the same progestin. Norethindrone acetate is agestin. We use that all the time. And that is different from norethindrone. Norethindrone is the mini pill. And you can see there's a big difference in concentration here. They're different molecules, and we'll talk about these specifically because I think norethindrone acetate is really interesting. But norethindrone is the only one that's been shown to be a birth control. Norethindrone acetate has never been shown to be a contraceptive method. That said, we give it at really high doses. We're going to talk about why it's interesting, and it probably works as a birth control. You can give Norgestrel, that's Ovret, we don't use that. And then micronized progesterone, we give in the form of Prometrium. Remember, it's in peanut oil. I had a patient yesterday who's like, I can't take any progesterones because they're in peanut oil. I'm like, no, you can't take micronized progesterone, but I can give you progestins, right? Synthetic progestins are in not peanut oil, essentially. And then Crinone is a vaginal gel. So this isn't available in the US, but there's a lot of data on this. And it's a shame it's not available because it's a gel and it works quite well at protecting the endometrium. Okay. So commercial uses. So this is Prometrium. So progestins have been around for a long time, Provera specifically. Micronized progesterone only became available in 1980, even though natural progesterone, right, not micronized, has been available for quite a long time. Everyone's like, what's the dose I should use if I'm doing this for hormone therapy? It's 100 milligrams daily or 200 milligrams cyclic. Both have been shown to protect the uterus. So whichever one works, all right? The gel is the 4% Crinone. That has been shown as well. It's not available here. The most important side effect of Prometrium is that it has a neurosedative effect. It has to do mainly with the metabolite. So it metabolizes into these neurosedative molecules. And so people get really drowsy and a lot of people can't tolerate it. Progesterone, micronized progesterone also isn't that well absorbed. And so there are plenty of patients who are taking Prometrium and we're giving them, not too much estrogen or a reasonable dose of hormone therapy for menopausal symptoms. And they start bleeding and they're getting proliferation. And it's because they're not absorbing the progesterone. So that's one thing to know. I love using it, but it's not the end all be all for all patients. Some people need higher doses, but then they're going to get a more neurosedative effect. You may say, well, why don't we give natural progesterone for bleeding? Because it's not that strong on the uterus. All right. If someone's having abnormal bleeding, natural micronized progesterone is not going to suppress it. It's certainly not enough to suppress ovulation the way so many of the other progestins are. It's not as strong, but it's good enough for the small doses of menopausal hormone therapy that we're giving to protect the uterus for most people. What's interesting about progesterone is that it doesn't affect the androgen receptors, the glucocorticoid receptors, or SHBG levels like the synthetic progestins do. It really just acts on progesterone receptors. It may even block mineralocorticoid receptors and lower blood pressure. So there's this question of, does it decrease water retention, where we see the other ones increase water retention, right? Because they're actually targeting those receptors. It has a weak proliferative effect on the breast, right? So you will see an increase in breast density, but there is no known, as far as we know, data now on increase of breast cancer if used for less than 5 years. This is questionable. This drug has not been around in widespread use as long as something like Provera, that we have very good data on, right? In terms of breast cancer, but in vitro studies, right? So in animal and lab studies, it doesn't seem to target breast cancer cells. So it does appear to be safer at the level of the breast. In the US, you can only get tablets, but in other countries, they have the gel specifically for breast tenderness, which I found so interesting, that they're like, it decreases breast tenderness, because we usually think that progesterone increases breast tenderness, but it's probably more estrogen that does that. And they have it as a ring or a suppository, and there used to be an actual progesterone IUD, but that's not available. All right, so that's it for commercial uses of micronized progesterone. Let's talk about medroxyprogesterone acetate. We use this all the time. So this looks structurally similar to progesterone. I'm just going to go back and you can kind of see the 21 simple structure in the upper right. And then here it looks relatively simple, but you've got all these kind of this like acetate and weird other attachments that the chemistry majors can explain. But it's a really strong progestin. It's the strongest at the level of the endometrium. So we always discount Provera. It's actually really the best when it comes to abnormal bleeding. It may inhibit ovulation in oral form, but it has not been studied as a contraceptive. But we know that in Depo, right, Depo Provera, you give people a huge amount of this, it absolutely does. It is more likely to cause vasoconstriction. So if you look at the Women's Health Initiative study, they looked at, cardiovascular disease in people that were given a conjugated equine estrogen and this pill in 2.5 milligrams, right? 2.5 milligrams of medroxyprogesterone acetate. The people who were in the Provera group, those that had a uterus, had higher rates of cardiovascular disease than those that were in the estrogen alone group. We know that similarly for the breast cancer group, but we don't talk about it for the cardiovascular disease group. So it points to the fact that Provera is also probably a little bit more toxic at the level of the heart. There's a question about an increase in VTE, but and that's really based on epidemiologic data. When they've actually studied this, there is no actual effect on clotting factors. It is an agonist of the androgen receptor, but it does not lead to androgenic side effects. When they've given this, they actually give this to men, they give Provera to decrease their testosterone levels. It lowers SHBG levels, and it has a strong affinity for the glucocorticoid receptor. This is why people say they feel more bloated when they're taking it. All right, so that's one of the major side effects, and it's different than natural progesterone. In mammary tumors, it has a potent capacity to increase them through mitogenic signals. It stimulates the mammary epithelium. And we know this from the Women's Health Initiative. We know this from lab studies, and we knew from the WHI that it was the Provera that was the culprit in the increased rates of breast cancer. And I can talk about that those increased rates were quite low. Overall, it was about 8 per 10,000. And the WHI was never designed to look at breast cancer. So the people weren't randomized. It was actually a cardiovascular disease study. So there were actually different rates of risk in the different randomized groups. I have multiple talks on this, but either way, if you believe that progestins are toxic at the level of the breast, it's this progestin specifically. That's where the data is. All right, let's talk about norethindrone acetate. So this is known as norepinephrine. You'll see that like in the British literature. And I'm like, what are they talking about? Is that different? Or agestin? We use it as agestin. It is twice as potent as natural norethindrone. And I say that because it's interesting, right? We know that norethindrone in a 0.35 milligram works as a contraceptive method, not by suppressing ovulation for all. For some it does, but mainly by, increasing cervical mucus, decreasing the endometrial lining, tubal motility. So you can imagine if we're giving people 2.5 or 5 milligrams of this drug that's already twice as strong, it probably is dang good, right? As a contraceptive method, but for some reason it's never been studied. The main difference between this and all other progestins, and this was so interesting when I started researching this, is it converts into ethinyl estradiol. Multiple studies have shown this. So I have the pathway here, where if you start with norethindrone acetate, it just basically it goes into this norethisterone and then ethinyl estradiol, like two steps. You get ethinyl estradiol. It is the only progestin that does this. This is why it works so well for add-back therapy, right? You're like, we give people a progestin when they're on Lupron, and we're like, why would that protect their bones? Why would it mitigate their hot flashes, right? Because hot flashes really are mainly estrogen related. Some people, you can give them some progesterone, but really it's an estrogen deficiency symptom. That's why it works. And the reason I think this is important is that we give a lot of people Agestin. I love this drug. It's fabulous for abnormal bleeding. It's fabulous for ovulation suppression, but we are giving it to people that have increased risk of blood clots. I've seen us give really high doses, and this is not the progestin to give. All right? You don't believe me? You can argue with me. It's converted. There is not clinical data, right? So I looked it up. There's no study, but it's because it's never been given. And I would argue it's because it's never been given as a primary form of birth control like we give to young people where we see that increased risk. But if you can tell me that basically you get 1 5 milligram pill, and I've studied this, of Agestin is equivalent to 30 micrograms of ethinyl estradiol. So that's a 30 microgram pill. It has affinity. So I just put that out there. We're not, it's out there. There is affinity for the androgen receptor. So that's why you will sometimes get these side effects of testosterone-like side effects. And it lowers SHBG. It has beneficial effects on bone mineral density because of the estradiol. It seems to have neutral effects on cardiovascular disease. And then there's this question of what it does for breast cancer. It's definitely less than that of Provera, but in vivo studies have shown more risk than natural progesterone. So it's kind of in between. So for people that really don't tolerate natural progesterone, we try to avoid long-term Provera. Again, I think Provera is a fabulous drug in the short term. In the long term, this drug is a really nice one. Unfortunately, norethindrone acetate is only available in 2.5 and 5 milligram pills. So the best we can get is to cut it in half. When we're using this for abnormal bleeding, for dysmenorrhea, for endometriosis, that's great. Those are good doses. But if we're using it for menopausal hormone therapy in natural birth in combined birth control, even with the high doses of ethinyl estradiol, it's usually 1 milligram of norethindrone acetate. And that's really all you need for postmenopausal patients as well, probably even less. So it's a little trickier. So for this, I usually will do it cyclic. I don't give people Agestin every day when they're getting menopausal hormone therapy. The other cool thing about norethindrone acetate is it is actually available transdermally, or norethindrone is. So one of the hormonal patches we use, Combi patch, uses norethindrone. And it uses I just had a patient yesterday, it's like a 0.15. It's a low dose, but it's a transdermal. So it's going directly into the bloodstream. So you can get this transdermally. It's too bad it's not, on its own, but it's combined with estradiol. Another one you can get transdermally is levonorgestrel. So this is our second generation progestin. We can find it and the reason I put it here is you can get it as a solo medication because we see it in emergency contraception and we see it in IUDs. It's at a 1.5 milligram dose as an EC. So we know that it's a little bit less effective at higher BMIs. And I said it's also absorbed through the skin. So this is what's in Climera Pro. I saw a patient yesterday who was switched from Climera Pro to the Combi patch because they thought that the Combi patch had more progesterone than Climera Pro. And that's not true. It has a different form, right? This is levonorgestrel. You need lower doses to achieve the same effect. Think about, and Combi patch is norethindrone, so it's at a little bit higher dose to get the effect. Levonorgestrel has a strong affinity for progesterone receptors, and it has some weak androgenic activity, and we see that in the symptoms. But it doesn't have effects on mineralocorticoid, glucocorticoid, or estrogen receptors. So really the main side effect we see with this medication, as we know, is androgen effects. The majority of the third generation progestins metabolize into levonorgestrel. So they can also have a little bit of a weak androgenic effect, but again, it was a marketing ploy. It wasn't these are better. Most of them turn into levonorgestrel. It also has a little bit more of an effect on breast tumor cells. This is all kind of in vitro studies, more than pure progesterone. So again, the kind of theme of the progesterone and breast cancer takeaway is that natural progesterone seems to be the safest, and the synthetics may be a little bit more risk. Okay, the last available progestin is drospirenone, and that's the one that's commercially available. Do you see how different this structure is? This thing looks so different. So I don't even really consider this a progestin. And the reason I love drospirenone, and it's not, right? It's an aldactone derivative. The reason this is such an awesome drug is that it really seems to not affect progesterone receptors in other parts of the body in the same way. And I love this medication for people that are sensitive to progesterone and progestins. All right. So as a progestin only pill, it's SLIN. It inhibits ovulation in 80% of people. It's amazing. The other progestin only pill, norethindrone, doesn't do that, right? It's less than 50%. This works like a combined hormonal contraceptive, but it doesn't have any estrogen. Strong agonist at the progesterone receptor. It blocks mineralocorticoid and androgen receptors, right? So basically, when you're giving this in 4 milligrams, you're getting it's basically 3 milligrams, which is what you see in the combined pills, is equivalent to 25 milligrams of spironolactone, right? It's very anti-androgenic. It is the only progestin that has been shown to be a benefit in premenstrual dysphoric disorder, which I'm going to get into for a few minutes. It's FDA approved for the combined pill. There's obviously a controversy we know about increased risk of VTE. I wrote a paper about this in residency. Retrospective studies showed a potential increase in risk in the combined drospirenone pills. The prospective studies did not show this. But what some people now think is that levonorgestrel was OCPs were the pills they were most comparing drospirenone pills to, and levonorgestrel probably actually counteracts the procoagulation properties of ethinyl estradiol. So it's actually probably a little protective, the levonorgestrel pills. I don't think drospirenone significantly affects the risk in a way that I would change management. And we don't have data on these drospirenone only pills. And I think that it's probably way less risk because you're not combining it with ethinyl estradiol, which we know significantly increases clot risk. We don't know the effect on breast cancer. It really hasn't been studied. This drug has really mainly been for reproductive age people for birth control, but it does increase breast density, right? All of the progestins do. Okay, I'm going to spend the last few minutes talking a little bit about some of the reproductive mood changes because I think this comes up a lot. So premenstrual dysphoric disorder is defined as a sensitivity to which hormone? Estrogen, progesterone, testosterone, or the withdrawal of estrogen and progesterone? Is it A? Is it B? We don't know. Is it C? Not really. Is it D? Most people think it's D. Okay, so you think it's the withdrawal. So PMDD is that withdrawal, right? That like the moody change you get the day before your period. Okay, so I'm going to define PMDD for you. So in PMDD specifically, the symptoms that start in the final week before the onset of menses, and it starts to improve within a few days after the onset. And it can be depressed mood, anxiety, tension, affective lability, instability, or anger. You have to have, it's a very complicated thing to make this clinical diagnosis. You actually need to like have a diary and like, keep notes for like several months. But at the end of the day, it's the luteal phase. It is a progesterone sensitivity. It peaks in the luteal phase when progesterone peaks. So that's the definition. And this is the progesterone. Where you see these high levels of progesterone is where you see true PMDD. Now, there are patients that come in and they say, I have PMDD. And so what I do is I get out a menstrual calendar and I say, tell me which days you have symptoms. And if their symptoms are specifically in the last 2 days, that's not technically PMDD. Now it's PMS. It is a premenstrual syndrome, but it's not premenstrual dysphoric disorder. And for those patients, I actually think it's probably more sensitivity to the drop in estrogen. Those are the patients that I'll give estrogen to, because when their symptoms get better is usually when estrogen starts to increase. Whereas if it were a drop in the progesterone, they would have kept their symptoms throughout their whole follicular phase, right? If what they need is progesterone. So those patients I give estrogen to. But for true PMDD, we got a problem. They're sensitive to progesterone, and progesterone is necessary for the uterus. So how do we think about treatment in the last few minutes? Remember that symptoms are focused in the luteal phase. There's no study that has shown any hormonal difference between women with and without PMDD. They come and check my hormones. I have a hormone imbalance. No, you don't. You have the same hormones as the person next to you that doesn't have PMDD. You're just more sensitive to them, right? It's a real condition. And we know this because there's a lot of studies, all right? If you look at their hormones, you're going to see more sensitivity. And there's very robust data that shows if you suppress all their symptoms, you give these people Lupron, not symptoms, their hormones, give them Lupron, shut down their whole hormonal axis, and then add back progesterone, they're going to have symptoms, right? So we just proved it's the progesterone. So how do we think about treating? Okay. There's no evidence that there's, sorry, this is a little bit off. The main type of treatment is going to be thinking about how do we suppress their progesterone levels because we need to suppress ovulation. This is the data on OCPs. Everybody's just like, well, give an OCP because you'll stop their period. The problem with OCPs is most OCPs have a progestin. And if you look here on overall symptoms, does not make it better unless they're taking drospirenone. So this is where you see drospirenone. There's one study that showed levonorgestrel, but it crossed the midline. So basically, most of the data we see is in drospirenone. And that's why the drospirenone only pill or the drospirenone combined pills are the only ones with an FDA approval. So this is the kind of gold standard on what's actually been approved. So sertraline, fluoxetine, paroxetine, so the SSRIs, and then a drospirenone only pill. There's off-label SSRIs. And then honestly, if you guys talk to me, my favorite is to, if they really can't tolerate anything, especially if they can't tolerate drospirenone, is I actually will give them Lupron with add-back with Duavie, which is a specific type of hormone therapy that we give in postmenopausal women that has conjugated equine estrogen and beta-doxaphene, which is a SERM. So it blocks the effect of estrogen at the level of the uterus. So this way you can suppress their progesterone, give them estrogen, and not worry about their uterus. And it's a really fabulous combination that I think has helped many of my patients. There are patients who will literally come in and ask for an oophorectomy. Now, if they ask for an oophorectomy, they need to trial Lupron first. Because if you give Lupron and their symptoms don't get better, this is not PMDD, right? This is something, or I wouldn't say it's not PMDD, taking out their ovaries is not going to make it better. And I do have those patients, especially the ones who are like, I have cyclic depressive symptoms, I'm on a birth control pill. And I'm like, it's not a hormonal issue. You're taking the same hormone every day. Doesn't mean you don't have cyclic depressive symptoms. It's not a hormonal cause. Okay, I'm gonna end here so that we have some time for questions, but I just want to talk about that, you know, everything related to progesterone really can affect what we call reproductive mood disorders. And there's a lot of places where we're going to see this in the patients we're taking care of specifically. So when we're managing hormonal contraception, when we're managing people who are ovulatory, pregnancy especially, right? Postpartum, and then in the menopausal transition. So we see that people who had really bad PMDD oftentimes have really bad menopausal mood symptoms, and they're trickier to treat because we need to kind of balance the progestin types specifically. There are newer treatments, especially with allopregnenolone, that seems to be beneficial for patients that have really severe postpartum depression, for example. For them, it may be the withdrawal of the progesterone, right? So we give them something that looks like it and it can help them. So those are kind of the newer things on the horizon. Reproductive psychiatry is really excited, and progesterone plays a really big role. So I'm just gonna skip through this. This is about major mood symptoms in menopause, and just say that we know that progesterone is way more important than just for endometrial protection. There's lots of different options out there, and hopefully I gave you some clinical pearls and also some basic science understanding. And I'm happy to answer questions now in the last few minutes. Thank you for having me. Question, Hannah? I would pick Provera because I think it actually works better. And I'm worried about the ethinyl estradiol conversion. If the bleeding is from, well, if that's a very good point, if the bleeding is from atrophy. But I was just thinking if someone had a blood clot, that depends on, yeah, it depends on what the cause is. So it's a good point that like if somebody, depending on what the cause is, right? If the cause of their abnormal uterine bleeding is proliferation, then you want to be giving something to block that proliferation. But when you see patients that have atrophic bleeding, so our postmenopausal patients on anticoagulation that keep bleeding, or they have a Mirena and they keep bleeding, those patients don't need more progestins, right? We keep throwing progestins at them and all we're doing is thinning their lining. So that's a very good point. And so for some of those, agestin might be good. And sometimes if they're, they don't have an active clot, I'll give them just estrogen back in general. But I think the point is that if you think they need estrogen, then agestin is a good option. So the question is about Depo-Provera and brain tumors, and I would have to look into that data because I think that again, it's an interesting question why, if there's any relationship, why that would be the case and not something like Provera, right, which has been around for a very long time and that people had been using for many, many years, and I've never seen Provera associated with brain tumors. Amy? So the question is, when do I think about using Megace? So remember, Megace is very structurally similar to progesterone. It's just a huge amount. The only time that I have ever learned to use it is in the setting of oncology for endometrial cancer, because it's so much more effective at blocking estrogen receptors and protecting the uterus, but it has many more side effects. And I typically would favor a levonorgestrel IUD over it because you're putting a high dose of progestin directly into the uterus. Another question? Yeah. I can share my slides with you, Jess. Yes. Are there any, yeah, Robin? Oh, really? Oh, I haven't prescribed it. Oh, okay, thank you for correcting it. Yeah. Oh, there's a question about Crinone. I always thought it was unavailable in the US, but yeah, it's available, so we can use it. I feel like it's usually used in the REI world, but we don't use it as much here. Yeah. Okay, for the peanut allergy folks, Crinone. Anything else? All right, well, it's 10 o'clock. Thank you guys for your attention. Have a good rest of your day.